evening, everybody. Good evening, everybody. Thank you for joining us. G-ECHO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. This session runs every Monday evening at 6 o'clock, so please do join us on those times. We've got Dale Petersen today from the University of Stellenbosch, Tygerberg Hospital, and he's going to be taking us through pre-malignant conditions of the stomach. Please do feel free to use the chat for questions. Thank you, Dale. We look forward to your talk.
Thank you, Dr. Galia. Is that fine?
Yes, looks good.
Got it. Can I go? Okay, good evening, everybody. Thank you for this honor and privilege to present this case or this presentation. Without further ado, so firstly, gastric cancer is one of the 5th most common causes of cancer globally, and is one of the 3rd most commonest causes of mortality worldwide. There are high-risk areas such as Asian countries such as Japan, China, Eastern Europe, Central and South America, as well as low-risk areas such as South Asia, North America, New Zealand, as well as East Africa. Reassuringly, the gastric cancer incidence has been reduced, and this has been attributed to the eradication of H. pylori, improved hygienic standards, as well as a diet that is more sensible in terms of fruits, vegetables, and a more nutritious form of living. Unfortunately, most patients who present with symptomatic disease are found to be in an advanced state, with a 5-year survival rate in Japan, a high incidence area being around about 90%. And this is due to the early diagnosis and early treatment of your more early forms of cancer. The 5-year survival, unfortunately, is dismal globally, 25%. As mentioned before, depending on whether you live in a high-risk or low-risk area, these survival figures vary. Most parts of Africa are considered low incidence, although there's a paucity of data with regards to the South African demographic. There is a male predominance, and histologically, gastric cancers by far, most of them are adenocarcinomas, and they can be classified according to the Lauren classification to 3 distinct subtypes. The most common one being in the intestinal type, which follows your more traditional environmental dietary risk factors. These are more commonly found in the elderly, involves more the distal portions of the stomach, and these are more closely associated with your pre-malignant lesions that follow the Korea cascade. The diffuse type is one that is sort of, as said, lacks glandular structure and tends to be a more proliferative form of gastric carcinoma, characterized by signet ring cells, which are mucin-filled. They tend to be present more in younger patients and have a very worse prognosis because of its diffuse nature. And on endoscopy, what is typically found is a poorly distensible stomach with a cobblestone appearance, should alert one to the possibility of a gastric adenocarcinoma or Leonitis plastica, which is associated with this. So with regards to the intestinal type, clearly you can see a more cuboidal type structure, more glandular type structure compared to the diffuse type, which is more disorganized form and also lacks a more structured glandular format. As you can see with Leonitis plastica, this cobblestone-ish appearance of the stomach, which is then poorly distensible, and this is strongly associated with a diffuse type, again, adenocarcinoma of the stomach. Gastric cancer can further be divided into location or classified according to its location, whether it's proximal or distal. So the esophageal gastric junction is usually your measuring step or your measuring baseline. Above the gastroesophageal junction, as well as in the cardian fundus, the body, and the antrum, depending on where that is found. The CVIT classification further delineates your junctional tumors according to its relation to the upper esophageal junction. So 1 to 5 centimeters above would be a CVIT 1, 1 centimeter above or 2 centimeters below would be a CVIT 2, and 2 to 5 centimeters below the junction would be a CVIT 3. Furthermore, it can be subdivided into molecular subtypes depending on the molecular behavior of the cancer. So chromosomal instability as well as microsatellite instability are your more aggressive forms of disease. Epstein-Barr virus is also strongly associated with gastric cancers, and your genomically stable tends to follow a more indolent course. So where does this all start? It all starts with pre-malignant lesions and being able to identify these lesions early so that we could potentially prevent further malignancy. So chronic gastritis, chronic atrophic gastritis, intestinal metaplasia, dysplasia, gastric polyps, previous gastrectomy, peptic ulcer disease, and Meniere's disease are all considered pre-malignant lesions. So pre-malignant lesions involves a complex interplay between genetic and environmental factors, with Helicobacter pylori being a central risk factor for the development of gastric carcinomas. More than 90% of chronic gastritis are colonized with Helicobacter pylori, and it accounts for more than 70% of non-cardia gastric cancers, with virulent strains carrying the CAG-A and VAC-A mutation. Furthermore, genetic and epigenetic alterations do also occur. So what is the incentive for identifying these lesions? We want to know how these lesions progress towards gastric cancer, as very little is known. Improve the risk stratifications of patients so they can be identified early and ultimately prevent gastric cancers and improve survival. So the histopathological stepwise progression from a normal mucosa to chronic gastritis, atrophic gastritis, with Helicobacter again being central to this, with associated dietary and genetic factors playing a role. One then follows this stepwise progression from atrophic gastritis to intestinal metaplasia, dysplasia, and then the more common intestinal type of gastric cancer. There are multiple risk factors, but the definite ones are chronic Helicobacter pylori infection, chronic atrophic gastritis due to the robust type 1 T cell response or inflammatory response, smoking, adenomatous gastric polyps, dysplasia, EBV, prior gastric surgery, especially Billroth 2, apologies, has a high risk, and intestinal metaplasia. The genetic factors, first degree family history, females, funnily enough, with genetic predisposition, the incidence is far higher in the female population. And then your FAP-associated fundal gastric polyps, and then your non-hereditary polyposis, colorectal cancers, and juvenile polyposis and Pew-Chafer syndrome are your genetic types. The other traditional risk factors are actually not really, there's no real hard evidence for them, but they are at best probable risk factors. For example, high sodium intake, previous history of gastric ulcer, and then raised BMI, obesity. We know that obesity is an inflammatory phenotype, and obesity is strongly associated, especially with your non-cardia gastric adenocarcinomas. Pernicious anemia or autoimmune atrophic gastritis, snuff tobacco, nitrates, heavy ethanol use. This is more associated with gastric cancers if a patient has alcohol dehydrogenase polymorphisms, low socioeconomic status, and this is more related to Helicobacter pylori transmission and Meniere's disease and hyperplastic gastric fundal polyps. So Helicobacter pylori, we know, is a class 1 carcinogen. It has been there in excess of 58,000 years and has evolved to such a degree to avoid the host's defense system, the acidic milieu within the stomach, and also to avoid our immune modulation and thus penetrate our epithelium effectively. So how it does this, there are two major virulence factors, CAG-A. So Helicobacter pylori can attach itself to the gastric epithelium, inoculate CAG-A into this epithelial cells, and this then interacts with tyrosine phosphorylases and then causes morphological changes within the cell, enhances cell proliferation. In addition, it sheds its cell wall, which then also initiates a pro-inflammatory response. VAC-A has 6 steps in which it does this. Direct interaction with cell surface receptors. It can undergo pinocytosis, endocytosis, form channels within the epithelial cell so that it gains entry within the epithelium and disrupts the internal homeostasis, resulting in apoptosis, vacuolization, and a pro-inflammatory state. Furthermore, it can traverse tight junctions and inhibit your T-cell regulatory activation or your surveillance T-cell response. So the first pre-malignant lesion or chronic gastritis, we know can be divided into diffuse enteral type gastritis, which is strongly associated with Helicobacter pylori, the environmental metastatic atrophic gastritis, and your autoimmune metastatic atrophic gastritis. This one usually has autoimmune overlap with autoimmune thyroid disease, as well as your type 1 diabetes, as well as other connective tissue diseases may also be associated with this. This typically tends to occur in the younger patient population. Females tend to be more affected, and pernicious anemia is actually a late complication of this disease. So how does Helicobacter pylori actually promote carcinogenesis? So it depends largely on where it colonizes. So if you have an enteral predominant gastritis, what happens is you get localized inflammation, you get inhibition of somatostatin, and somatostatin is an inhibitor of gastrin. So with somatostatin being downplayed, gastrin levels increase, and gastrin then stimulates your acid secreting cells to increase acid production. This is then associated with a lower degree of atrophy, which then results in the propensity to form duodenal ulcers, which occurs in 10 to 15% of patients. On the other hand, the more concerning one would be your corpus predominant Helicobacter pylori or corpus predominant gastritis. In this case, somatostatin is inhibited, gastrin goes unchecked, and gastrin causes parietal cell hyperplasia and eventual atrophy and inflammation within the corpus, and this results in atrophy and predisposes to gastric carcinoma. So this just highlights the stepwise progression of enteral gastritis to form a duodenal ulcer, as well as your corpus predominant, which tends to form a pangastritis. And this has two essential outcomes, the one being following down your metaplasia, dysplasia, and intestinal type carcinoma, or your normal carcinomatous sequence, and the other one being gastric ulcers. Gastric ulcers by no means is a benign process. The question that is very contentious is, what is the point of no return? So what dictates whether a patient goes down the metaplastic, dysplastic carcinomatous sequence versus forming a gastric ulcer? And at which stage do you reach a point where reversibility is no longer achievable? This is still a contentious topic. So testing for Helicobacter pylori is very important. So we get non-endoscopic and endoscopic testing. Stool antigen testing is important. Its advantages, it can assess for active disease. It can be used before and after treatment, but the disadvantages would be exposure to antibiotic therapy. Your urea breath test, again, advantages for active before and after treatment has been initiated. The negatives are that availability, antibiotic use, as well as a small dose of radiation is actually elicited to the patient. And then we have your serology testing, your IgG testing. It's widely available, very inexpensive, has a good negative predictive value. But unfortunately, prior exposure or prior treatment, even successful treatment, your IgG antibodies will still remain elevated. Endoscopic tests are your histology, obviously gold standard in terms of sensitivity and specificity. And in addition, it actually gives you a lot more information on what's going on in the mucosa in terms of presence of metaplasia, dysplasia, or atrophy. Culture, 100% sensitive and allows for antibiotic sensitivity testing. There's a paucity of data with regards to Helicobacter resistance pattern within the African continent. And the disadvantages to using culture, technical difficulty, and again, you require a good gastrohistopathologist in order to fully interpret your histological specimens. Your rapid urea test, it's rapid, it's cost effective, it's accurate, and even patients who are off PPIs or antibiotics. The disadvantages, though, is that after treatment has been initiated, or PPI use can create a negative or falsely negative test. PCR is excellent for assessing the resistance pattern within your community, but the disadvantages are it's not widely available, and in a resource limited environment such as South Africa, it's relatively expensive. Okay, so the diagnosis of choice is usually upper endoscopy, and especially with regards to non-healing gastric ulcers, where 6 to 8 biopsies of the edge and the base are actually recommended. The American Gastric Association actually recommends that patients over the age of 55 with new onset dyspepsia or younger than 55 with alarm symptoms should undergo endoscopic investigation, and failure to empiric antibiotics and PPI therapy should undergo endoscopy. Chroma-endoscopy, magnification endoscopy, and narrowband imaging can be used to elicit this. So Helicobacter pylori, why do we eradicate? It's to limit chronic inflammation and oxidative stress and reverse pre-malignant lesions. Many randomized controlled studies, especially in high-risk China, have looked at the Helicobacter pylori's effects on regression of pre-malignant lesions, and it's actually found that it did reduce the progression, specifically with intestinal metaplasia. Many meta-analyses show reduction even in patients who've had gastric cancer. Eradicating these patients, especially if patients have evidence of multifocal dysplasia and which have a potential of recurrence. Even in resected early gastric cancers followed by Helicobacter pylori eradication, there seems to be a reduction in gastric cancer incidence. So this just really illustrates the benefits of eradication versus no eradication. So the relative risk for non-cardiac gastric cancers, intestinal type and diffuse type in patients who have been eradicated is significantly improved. The hesitancy to eradicate patients is this a proven fact? There has been an association where H. pylori eradication is actually inversely associated with esophageal adenocarcinoma, meaning patients who have been eradicated, there seems to be a trend towards a higher risk or higher incidence of esophageal adenocarcinomas in these groups. In Mexican adult populations showed no benefit of H. pylori eradication in preventing histological progression, and the number needed to treat in high-risk groups being 15, and your low-risk groups, which the African continent has been deemed, requires 245 to treat before you prevent a gastric cancer. So in China, there's been no overall benefit, group benefit in patients receiving eradication, and the reduction in gastric cancer was only noted in patients who actually did not have precancerous lesions. So the question is, what is this point of no return? So with regards to atrophic gastritis, this is patients that have been eradicated. You can see that there has actually been a notable grade regression within atrophic gastritis compared to those that have not been eradicated over a given period of time. Intestinal metaplasia tends to be a lot more resistant to regression post-eradication, and this is clearly shown that a significant drop in progression is only seen usually after about 2 years of sustained acid suppression therapy. So H. pylori resistance patterns is concerning. It's on the increase for all of our backbone drugs. And these are the global resistance pattern. Of interest is that no data exists for the African continent for clarithromycin resistance, metronidazole, levofloxacin resistance. This just basically is your stepwise therapy. My colleagues before have gone through this in their previous presentations on approaching eradication in patients who have failed or patients who have resistance strains identified. Okay. So before one thinks about resistance, one should also ask other reasons for failing with regards to eradication. So non-adherence to therapy, patients who may be experiencing side effects related to antibiotics should also be explored, and intragastric pH lowering, appropriate PPI dosing, frequency, potency, and other concomitant drugs or foods that may affect the efficacy, genetic factors, smoking, lifestyle changes, and then also resistance should also be interrogated, specifically your KAGA and FACA mutations. Okay, some research has been done on protective factors. So none of these factors have actually been fully established. Looking at the use of NSAIDs, what's been known, NSAIDs and aspirin, Gastric cancers tend to overexpress COX-2 in 70% of gastric cancers, but in the UK, large cohort study didn't show any benefit to the use of aspirin, only non-steroidal anti-inflammatories, and there was no regression in intestinal metaplasia noted even after 2 years of using COX-2 selective inhibitors. H. pylori eradication plus COX-2 for 24 months was shown to cause chronic atrophic gastritis regression. Aspirin, only a benefit was noted for at least 10 years of therapy with 300 milligrams, which is far beyond the secondary preventative doses that one usually uses. High dose ascorbic acid, diet high in nutritious vegetables and fruits, and then statin use has been shown to have anti-proliferative, anti-proptotic effects. And then also green tea consumption has also been looked at. Then with regards to atrophic gastritis is essentially the loss of gastric glands with or without the presence of metaplasia. And this is basically due to the robust inflammatory response caused either by Helicobacter pylori or an autoimmune mediated process. This results in the reduction or absence of intrinsic factor and hydrochloric acid. So you get a low acid secreting state. And this essentially results in a risk of 0.1 to 3 annual risk for developing gastric cancer. The risk associated depends on the extent and the presence of concomitant intestinal metaplasia. So pernicious anemia, which tends to be corpus predominant autoimmune mediated, has a 7-fold increased risk for developing gastric cancer, and corpus predominant autoimmune gastritis. In addition, the risk of neuroendocrine tumors is also of concern. So how this evolves, you get parietal cell loss, a reduced low acid state, hypergastremia, and gastrin is a growth factor, intrachromophaffin-like cell hyperplasia, and this evokes dysplasia and predisposes to malignancy. So the difference between your autoimmune metastatic and your viral metastatic forms of atrophic gastritis, immune-mediated T-cell, B-cell mediated, environmental, H. pylori, prior or current infection. There tends to be an autoimmune overlap, as we mentioned before, type 1 diabetes and other autoimmune thyroiditis. These tend to be antral sparing or corpus predominant, and one tends to find reduced pepsinogen 1 to 2 ratios, and you get an overt hypergastremia. And these tend to be associated with other forms of carcinoid tumors, gastric carcinoid tumors. The reassuring aspect of environmental metastatic is that they are potentially reversible with H. pylori eradication. They tend to be antral predominant, and serum pepsinogen levels tend to be more variable, with a slight increase in gastrin. And as we mentioned before, that gastrin only slightly increased means a lower growth factor stimulatory effect induced within the mucosa. So atrophic gastritis and intestinal metaplasia, these entities often go hand in hand, and this is divided into 3 categories. You get your type 1, which is your complete type, and these are goblet cells, which tend to be mature, well differentiated, and these are not usually associated with the risk of gastric carcinoma. Whereas your type 2 and type 3, your incomplete forms, are notably associated with increased risk, 20-fold increased risk of gastric cancer. And early gastric cancers with your type 3, your less differentiated form, is 42% in patients at 5-year follow-up. A prerequisite of this is metaplasia induction, which is a prerequisite resulting in the loss of acid-secreting parietal cells, the induction of atrophy and metaplasia. So one of the biggest questions within this whole carcinomatous progression is metaplasia a repairable process, or is it indeed a failed attempt for the body to actually repair chronic inflammation? Furthermore, from metaplasia, we can then progress toward gastric dysplasia. So low grade and high grade gastric dysplasia. Low grade tends to be reversible. It can regress in about 60% of the cases, and about 10 to 20% of these cases progress toward high grade dysplasia. So your high grade lesions rarely regress. It has a 2 to 6% annual incidence for gastric cancer, with a 40-fold increased risk of progression. And these can either be synchronous, At the time of high-grade dysplasia, you can actually have other focuses of malignancy, and they may be unifocal or multifocal. So how do we assess for these lesions? Endoscopic evaluation is crucial. So we need to ensure excellent mucosal visualization, looking for color changes, texture changes, assessing the submucosal vessels, and looking at the ruggy or architecture, loss of gastric folds, in the case of atrophic gastritis. And furthermore, what's been shown to improve or enhance irrigation of your gastric mucosa are defoaming agents such as N-acetylcysteine and sinmethasone, which is found to be superior to normal saline irrigation. Targeted examinations focusing on abnormalities using high definition white light endoscopy and narrow band imaging, and then taking concise photographic documentations of all your cardinal areas that need to be interrogated. So your Olga and your Olgam risk score looks at gastric atrophy and intestinal metaplasia. And just for the speed of explanation, the biggest risk factor is associated from stage 3 to stage 4 with progression toward gastric cancer. So this just helps in order to stage and to really risk stratify the patient with regards to disease progression. Furthermore, the modified Kimura-Takamoto classification is a popularized classification in Japan, which is one that's being recommended, which basically divides the stomach into various segments, looking at areas of maximal atrophy, assessing for the loss of rugal folds. And what this classification basically does is it assesses areas of maximal involvement and essentially helps to risk stratify. So the ones that tend to progress more towards C3 tend to be more corpus predominant, or the ones that tend to have a higher risk factor profile. And what you're looking for is loss of rugal folds, mucosal pallor, and increased visibility of especially of your submucosal vessels should be assessed. For example, in the images above, the patient has atrophy involving the interface between your antrum and your corpus, and this would be a C3 and would be designated as a C3 lesion. So high definition white light endoscopy, looking at loss of gastric folds, and you can clearly see a pallor, a mucosal pallor, submucosal vessels are more prominent. Narrowband imaging also helps to enhance visualization. And then also for the identification of intestinal metaplasia, looking at your light blue crescent sign, which looks at inflammatory, fatty, cuboidal cell deposition within the mucosa. Once this is identified, concise biopsies need to be performed according to the Sydney biopsy protocol, which requires at least 5 gastric biopsies to be placed in a separate labeled jar. And biopsy should involve 2 within the antrum along the less and greater curvature, within 2 to 3 centimeters of the pylorus, 1 involving the incisura, and then 2 involving the gastric corpus, 1 at the lesser curvature, 4 centimeters proximal to the incisura, and 1 in the middle portion of the greater curvature. The International Padova classification, which is essentially histological classification, looking at the grading of gastric dysplasia. So just to put the assessment of a patient with atrophic gastritis and intestinal metaplasia together. So once you have done your endoscopy looking for the features of atrophy and intestinal metaplasia, one then needs to document these areas according to the modified Kimura-Takamoto system. Biopsies are then taken according to the Sydney protocol, and the patients can then be placed on empiric eradication therapy. Once histology has been achieved, and once you have assessed the patient as being high risk versus low risk, depending on whether they're antral or corpus predominant. So if they are antral predominant or intrasural predominant or distal disease, no further surveillance is actually needed in the absence of dysplasia. And then in your high risk cases, corpus predominant lesions, especially if the patient has a family history of malignancy or the persistence of H. pylori despite attempts to eradicate, a 3-yearly endoscopic surveillance is indicated. In the face of dysplasia, this requires a more aggressive form of management. So further imaging and to assess the degree of penetration, with endoscopic ultrasound is needed, and also histological assessment for the degree and depth of penetration, whether the lesion has now gone submucosally. If it's gone beyond the submucosal surface, then surgical options would need to be explored. If it has remained within the submucosa, then one could consider submucosal resections as a possible alternative. So your non-endoscopic approach would be to test H. pylori, treat and confirm if that eradication has been successful, evaluate anemia, look for other micronutrient deficiencies, and then in patients with the autoimmune mediated disease, you should screen for other autoimmune conditions, check for pernicious anemia or parietal cell antibodies, intrinsic factor antibodies, and histological findings that should be consistent, and then treat appropriately. So endoscopic evaluation should be to obtain topographical biopsies, which would facilitate grading and further risk stratification. So advanced atrophic gastritis, every 3 years, these patients should be surveilled. And in patients who are newly diagnosed with pernicious anemia, one should presume that there is profound atrophic gastritis, and these patients should also be surveilled closely. So serum markers that have been used are pepsinogen 1 levels, and looking at the ratios between pepsinogen 1 and pepsinogen 2. So pepsinogen 1 tends to be corpus predominant, pepsinogen 2 tends to be produced by antrum and cardia, and this gives an indication as to where which part of the gastric mucosa tends to be predominantly affected. So pepsinogen 1 levels lower than 70, pepsinogen 1 to pepsinogen 2 ratios less than 3, actually has a very good sensitivity and specificity for the diagnosis of gastric cancer, 69 and 73% respectively, as well as for atrophic gastritis, 69 and 88% respectively. So with regards to pepsinogen level screening, it has been shown that patients at the age of 50 have a reduced lifetime risk of intestinal non-cardiac gastric carcinomas in 24% of patients when being screened for using your pepsinogen ratios. Your tumor markers have a very low sensitivity and do not really have a place. So now moving on to gastric polyps. So gastric polyps, these can be specifically epithelial type, can be divided into fundic, which is about 50%, and these can be assessed according to their dysplastic potential. Sporadic being really benign, not really associated with malignant progression, less than 1%, as well versus your FAP or your familial associated polyposis syndromes. These have a 25 to 40% risk of dysplastic progression. Hyperplastic polyps are found about 40%, and adenomatous polyps in about 10% of all gastric polyps. So by far your fundic polyps, these tend to have a lower association with H. pylori. They tend to be more common in PPI users, and your hyperplastic form, these tend to be H. pylori positive, and they tend to be less likely to be associated with PPI use. The one that's really of concern is your FAP-associated polyps. 20 to 100% of FAP patients would have fundic gastric polyps, and this is due to APC gene mutation. And what you get is this carpeting of the body of the stomach. There's actually the difficulty in this is that there is no real evidence to show that one can actually macroscopically differentiate between the sporadic and the FAP-associated forms purely based on endoscopy. So histological diagnosis is important, although if one sees a comprehensive carpeting of the stomach, this should alert one to the presence of FAP. The malignant potential is that at 35 years of age, 95% of patients with FAP will have polyps and in excess of 100 adenomas. And the mean age for colon cancer in these untreated patients is actually as early as 39 years of age. So very aggressive form of disease. So what the recommendation is that a biopsy should be performed of disease unless these lesions are in excess of 1 centimeter, then one should consider polypectomy. Polypectomy for sporadic fundic gastric polyps should also be considered, depending on the size of the lesion. And then in order to reliably exclude dysplasia, carcinoma, as well as the need for excision, endoscopic histological diagnosis is crucial. So in patients with numerous fungal gastric polyps who are younger than 40 years or have dysplasia, colonoscopy should be performed to exclude FAP. But the evidence for this is very sparse. If no dysplasia is seen, no follow-up is required. If dysplasia is present, this would be a strong motivator to perform an endoscopic assessment. Hyperplastic polyps have little, if any, neoplastic potential. The question here is simply biopsy them versus performing a polypectomy. But this would also depend on whether the polyp actually has high-risk features or not, which I will delve into shortly. So it has a 1 to 19% dysplastic potential, 0.6 to 2% adenocarcinoma risk. They may be either sessile or pedunculated, and they typically affect the antrum. And as we know that they are commonly associated with PPI use. The recommendation is to biopsy these lesions, especially if they are, unless they are more than 1 centimeter, then one could excise them or perform a polypectomy, test and treat, test for H. pylori and eradicate, or the test and treat strategy should be employed. And then surveillance should entail a single repeat endoscopy at 1 year. If the polyp persists or if there's dysplasia present, polypectomy should be performed. And especially if dysplasia, then grading of the dysplasia is crucial. And this would also dictate your follow-up endoscopic plan. No polyp and no dysplasia would require no further follow-up on the single repeat endoscopic examination. So your adenomatous polyps, these are deemed to be true neoplasms, and they are precursors for gastric cancer in about 6 to 10% of cases. So they can be flat, sessile tubular villus or tubular villus, and they are frequently found in a solitary position. So there's no association with H. pylori infection. What really makes these lesions aggressive features, if they are greater in size, usually more than 2 centimeters, and if they have villus histology, they have a 28 to 40% risk of malignancy. The tubular adenomatous form tends to have a much lower risk associated with gastric cancer, about 5%. High-grade dysplasia, needless to say, has a high risk for the development of invasive gastric cancer. And the risk for the adenomatous polyps is that you actually may get a focus of high-grade gastric or high-grade dysplasia actually within the polyp itself. And these are usually associated with synchronous gastric malignancies. So that at this time of identification of the high-grade dysplasia, the patient in all likelihood may have a gastric cancer, an established gastric cancer. So the recommendation is complete removal of these lesions, examination, concise examination of the stomach, and focused biopsy should be performed. Endoscopic follow-up should be followed once a resection has been performed. 6 months, especially if incomplete polyp resection has occurred, if there's the presence of high-grade dysplasia, and a 1 year follow-up should actually be performed for all other polyps. Your harmatous polyps, briefly, so PJS and your juvenile polyposis and Cowden syndrome, these tend to have more associated with extragastrointestinal malignancies. And the recommendation is that upper endoscopy should be performed every 2 years after 18, and biopsy should be performed if more than 5 polyps have been identified, and remove any polyps that are more than or equal to 1 centimeter in size. Eradication of H. pylori is also recommended. So how do we assess polyps to determine whether they have aggressive features or not? So this is an interesting study, the SPACE study, which looks at experienced gastroendoscopists and to see what is the agreement or the consensus with regard to the assessment of gastric polyps. So what was found to be of importance is the color comparison, looking at the background mucosa, whether the lesion is the same, lighter or darker, the presence of an open or closed pit pattern, the surface, whether it's smooth, irregular, bumpy, or nodular, and then also your narrowband and white light assessments. So high-risk features, color, lighter or darker than the surrounding mucosa, if it has an open pattern, and if the surface is irregular and undulating. And your low risk features, uniform color, close pit pattern, smooth surface. So this just illustrates this. So if you look at this lesion, it has irregular edges with an open pit pattern, which would make it a high risk, demonstrating high risk features. This lesion, on the other hand, tends to have a close pit pattern, smooth edge, and tends to be more confluent with the surrounding mucosa, and this would be deemed as a low risk lesion. So other lesions of importance is Meniere's disease, which tends to be rare. It has a 15% association with gastric cancer. What this is essentially enlarged gastric folds with foveolar cell hyperplasia, edema, and varying degrees of inflammation. HIV and CMV is commonly associated, and H. pylori is commonly associated. There is actually no established recommendation regarding endoscopic surveillance in these lesions. And then previous surgery also has a significant risk, especially 20 years post-operatively at the anastomosis site. And what is believed to be the mechanism for this is a hypochlorhydria, which tends to cause bacterial overgrowth and nitrate formation, which tends to have a stimulator and inflammatory response toward the surrounding mucosa. Enterogastric reflux of bile salts and pancreatic enzymes have been also implicated in atrophy of the remaining mucosa due to low levels of gastrin has been also associated. BILROF2 by far has a higher risk, a fourfold higher risk, and it's believed to be associated with bile salt reflux. Peptic ulcer disease history prior peptic ulcer disease is associated with 8 times greater risk for gastric cancer. So the take-home message with regard to pre-malignant lesions is that these are potentially preventable, that H. pylori resistance is emerging and is progressing. And what is of concern is that our local resistance pattern remains to be described. And there is paucity of data with regards to this. And in order to early detect these pre-malignant lesions, one needs to be methodical with regards to your endoscopic assessment and taking focused biopsies, so that especially in patients who have high risk factors and especially in patients who are potentially difficult to treat patients. So thank you for your time, and that is my presentation.
Thank you, Dale. That was great and very comprehensive. Much appreciated. I'm sure we've all learned quite a bit. While we're waiting for you to type your questions in the chat box, Dale, 2 sort of practical situations from my side, I'd just appreciate your opinion on. We often have a situation where you find not just one solitary, but a couple 10, 20 hyperplastic polyps distally. What's your approach to that kind of situation?
So depending on the malignant appearance of these polyps and the size, so one would obviously have to assess the polyp to see, are there macroscopic features that are associated with malignancy. The irregular edge, the color of the lesion would make one, the pit pattern, if it's an open pit pattern, that would make one more concerned. So a good thorough surveillance and assessment of this lesion is important, but to truly delineate, one would have to perform at least a biopsy of those lesions to look at and to confirm that these are histologically benign. If they are more than 1 centimeter, the recommendation is that these lesions should be removed. But then one should also take into account the patient. So the history is important. The family history of risk for gastric cancers. Is the patient been on PPI therapy or high-dose PPI therapy for a long time? So one really needs to take a very good clinical history with a good endoscopic assessment. And once you've compiled these 2 modalities, then you can actually decide whether these are actually low risk. But the general consensus, multiple lesions within a given area, especially if it's a young patient, one would want to exclude things like FAP, which has a high malignant potential. So sampling those lesions would probably be the best way forward.
Thanks, Dale. Won't you stop sharing your screen?
Oh, sorry.
Yeah, I think, thanks. I agree with that. From a, looking for pit pattern and all of that is I mean, that's ideal, but from a very practical point of view, I think, snaring off whatever's bigger than a centimeter and sending it all off, not forgetting to biopsy the surrounding mucosa, which is often pre-neoplastic as well. So that's kind of a situation we see every now and then. And then one last thing, I'm sure you as well, often get chronic refractory peptic ulcer disease, which now you are telling me at some point it's going to get to a point of no return. When are you going to refer that patient to us? What is your time frame? How does it work with you?
So I mean, if in the context of a non-healing gastric ulcer that has been eradicated and has the recommendation is that you actually have to biopsy 6 to 8. Take 6 to 8 focus biopsies involving the edge and the base, and then if the patient has been offered eradication, then one needs to interrogate the presence of H. pylori and whether there's actually H. pylori resistance, and then tailoring your eradication strategy accordingly. And then things such as compliance, looking at dietary risk factor modification. Has the patient actually done what is necessary to achieve disease remission? And once biopsies are performed and we get a histological confirmation that there is dysplasia, atrophy, or features of malignancy, then one would have to consider resection if there are signs of malignant potential.
Yeah, I hear you. I think the smoking is a big. Yeah, we don't win with the smoking. And then they come back after their resection, they come back with a stomal ulcer. Yeah. Anyway.
And our patients love their grandpas and their anti-inflammatories, which also makes it challenging.
Yeah. There's a question from Nzamo, who congratulates you on your great talk and then wants to ask for your comments on the African enigma. Why increased H. pylori prevalence, but not an increased in gastric CA, comparatively speaking?
So when we say that there's an increase in H. pylori prevalence, one would need to interrogate whether these are actually the virulent strains. Not all H. pylori strains have malignant potential. We know that the CAG-A and the VAC-A mutations, these are the ones that are 90% associated with gastric cancers. So it'd be interesting to see what our environment offers. We know that our resistance patterns are also sparse. The genetic virulence factors associated with H. pylori has not been described. And anecdotally, I know that's not a good form of evidence, but from what I've seen at in our endoscopic center, we're seeing a lot of young patients presenting with advanced gastric cancers. So that is a concern, the diffuse type pattern. And we know that the diffuse type pattern not necessarily is overtly associated with H. pylori infection. So to answer that question thoroughly, I really don't know what that means. But I think it is a concern. We need to interrogate what strains we have and resistance pattern, because at this point in time, eradication is our best preventative strategy. And if eradication fails, then we're in deep water. So I think a lot of efforts need to be made to identify that. What are our resistance patterns in our country before we explore that?
There's a comment in our chat group that Ampath presented at SAGES a while back, and their clarithromycin resistance was about 15%, just for interest's sake.
Okay.
Would you, so it's quite high.
So that, So, I mean, that is exceptionally concerning, because that is our backbone first line regimen, which would be your clarithromycin and our amoxicillin regimen. We tend to, I think, the levofloxacin, just on general discussion with the TB prevalence in our country as well, I think a lot of guys are a little bit reluctant to move towards a levofloxacin based regimen, especially with the prevalence of HIV and TB and exposing patients to quinolone therapy. But the clarithromycin resistance aspect, that would necessitate the use of levofloxacin and escalating our management accordingly. But I think you want confirmation. That is the important thing. Is what is your local resistance patterns within your local community, which would be important.
Agreed. Would you agree with the statement that our high H. pylori rates inadvertently protect against OG junction tumors?
Well, this is it's a controversial topic. What they've noted, they don't know if this is a cause and effect, because what they noted in high-risk countries such as China, where they've eradicated, where there's a more greater surveillance, greater intensive, more robust eradication protocols, they have noticed an inverse relationship in OGJ adenocarcinomas. So the question is H. pylori protective in OG adenocarcinomas, or is it just an innocent bystander? I have not come across any literature that has put a concrete answer to that question. So I don't know. I don't know. There's not enough information to answer that.
I also don't know, but I think it's an interesting concept nonetheless.
Yes, definitely. Yeah,
there might be something to it. I don't know.
Definitely. And is H. pylori really this bad guy that it's being chalked up to be? I know Prof Ali will argue against H. pylori, just eradicating H. pylori for the sake of eradicating it. So it will be interesting to see what unfolds in the years to come.
Good, thanks, Dale. Anything else? Otherwise, I think we've gone through everything in the chat box. Yeah, I think that's
raised his hand.
Okay. Mashiko, do you want to go first? Sorry, I just see your name popping up there.
Thanks, Galia. I just put my hand up, but Joseph was first. I don't know if he wants to go.
Joseph, please go for it.
Thank you. Dale, thanks. Lovely presentation. I just I see that you have quoted the American Gastroenterology Association in terms of the age for endoscopic investigation for patients with dyspepsia. And I think that the American College of Gastroenterology uses, I think, the age 60. What's the recommendation for the African context? What age should we be endoscoping them? Thank you.
That's a very good question. I think that we don't really have a formalized protocols. I mean, if you look at what we are referring to, is we tend to look at what the developed parts of the world show, and we know that our climate is very unique. So this would be a call to us to maybe establish our own endoscopic surveillance program. But then again, we need research, we need the numbers, we need to do the studies in order to define our patients and appropriately risk stratify them. I think the age younger than 55 with new onset dyspeptic symptoms is a rational cutoff. Obviously, if the patient presents younger than that, then this would also be more concerning. So I think that is a reasonable cutoff. And dyspepsia in the face of alarm symptoms should always be taken seriously and interrogated. So I think that is a reasonable number. But for our climate, I think the history, I think a guideline is a guideline at the end of the day, and you should actually always tailor it to what's in front of you. So the younger, the more concerning, as always. But I think that's just a guideline as to what to do. So I think you really need to individualize your approach to your patient.
Thanks. Joseph, you happy with that? Then Mashiko.
Yes, I am. Thank you so much.
Thank you. Mashiko, your hand is up.
Thanks, Galia. Thanks to both of you. I think it was such an excellent presentation, Dale. And I think it was a very nice follow-up from the pernicious anemia talk last week.
Yes.
Yeah, excellent. Neo, so you're right that in the private sector, there was a 15% plus, I think even more, clarithromycin resistant. And this was probably published as an abstract because it was a SAGES abstract. So you probably find it in the SMJ. But interestingly, Dion Levine did a study here and there was 0 clarithromycin resistance. So I guess this speaks to the dual sort of healthcare that we have in the country, where you may find that because of prescribing practices, that you have a high clarithromycin resistance in the private sector and absolutely 0 here. But of course, I think, you know, all areas, as Dale says, it would be nice if we could have data both from the private and the public sector and compare. We do have data for metronidazole resistance. It's very, very high. So really metronidazole in our setting, we really shouldn't be using. But clarithromycin is probably patchy depending on where people are. Zamo, to answer your question about the African enigma, yes, it's a question whether it really exists or whether this just reflects a lack of data. But if you look at it with the data that is available, it does seem that the enigma exists. We've got very high prevalence of H. pylori, even higher than East Asian countries, and yet their risk of gastric carcinoma is phenomenally high. But of course, there may be other risk factors in those areas, which we don't have. And they've always postulated that we maybe have a protective microbiome, that maybe because we are exposed to helminth infections from a young age, that promotes a more anti-inflammatory Th2 phenotype and not sort of a pro-inflammatory T1 phenotype, hence we are protected. But all are questions that need to be answered, for which we have absolutely no answer. So yeah, we definitely need more data. But it does seem, if you look at the numbers of GCA published in the cancer registry, comparatively speaking, they are low compared to many places in the world. Why that is, we really don't know. Just for the fellows, this pre-malignant conditions and how you manage them is a very, very common question asked either in the written or the oral. So I would urge you, this was a beautiful talk. I would urge you to review it at your own time. It's a very, very important topic. And once again, thanks to both of you. I thoroughly enjoyed it and I learned a lot.
Thank you, Prof. Thank you, Dr. Galia.
Good. Thanks, everybody. And yeah, congratulations. Great talk. I think everything you need to know is here. So go and look, for those of you going to your exams, perhaps go and look at the recording again. It leaves me to thank Dale, to thank the ECHO UNM and the ECHO India team. Please remember to give us your feedback and give us suggestions. Remember, the recordings, as mentioned, are available on the Gastro Foundation website. And then a big thank you to Karen and the Gastro Foundation. And yes, wishing you all a good evening. Thank you.